It's my great pleasure to introduce my dear friend Fergal Monsell from Bristol, England. And it's interesting, I've never visited Fergal in the UK, but I've seen him in India twice. So that's how our friendship grew. So Fergal, are you ready for share screen?
Yeah,
Okay, great.
I can't share at the moment because Mark's still on.
Oh, okay.
Yeah, that's grand. Thank you. That's me there. Again, it's a very great pleasure to be involved in this. And I'm inspired and humbled by many of the talks that have gone before me. And in putting this together, I rather anticipated that it would be seeing a global perspective, but particularly in an environment that I'm not used to working in. And I thought, what can I provide to a forum like this? And I thought, well, actually, all I've got is what's in front of me. So I thought what I'd do is present what I perceive to be the advantages of living on a small island with socialised healthcare. The small island in question is that one, which is the United Kingdom. And a few facts about that. So my disclosures, my financial disclosures, I have none. My intellectual disclosures, basically I'm driven by curiosity and no scientific training or rigor. And also my disclosure of my privilege. Listening to these talks, I realized that my privilege is incalculable, as is most of the people I treat, and it comes nowhere near some of the things that you've demonstrated to me. And it is with that in mind that I give this talk. The UK is about the same size as Oregon. The population density is about the same as Connecticut. The per capita GDP this year in $1,000 the UK is around the same as the United States and Canada. But if you look at some of the other areas that have been presented today, we are 10 times wealthier in terms of GDP than a lot of the countries that have been on display today. And so that gives us many more advantages, many more ways that we can assist the patients that are in front of us. So my task really is the way I've taken it is how do we prevent post-traumatic low limb differences in a state the size of Oregon with a population density size of Connecticut with a GDP equivalent to USA. So the way I'm taking this talk is not showing severe deformity, etc., because we don't tend to get that. But it's more how do we prevent the very common deformity that we see certainly in the United Kingdom and globally, which occurs as a result of trauma, which is a very, very common global occurrence. And because we work in a constrained system, it gives us the opportunity to reorganize. And in 2012, the UK trauma was reorganized. There were significant changes in patient flow in that all patients meeting a major trauma criterion were directed immediately to a major trauma center. Clinical care was changed in that in these centers, patients could expect to be seen by senior decision makers. So there's a consultant delivered or certainly influenced system. And also allowed data collection so that we could see month on month, year on year, how this reorganization was impacting the care we were able to provide to patients. And so that in terms of the geography, we formed adult centers, combined centers and pediatric centers. And the centre I work in is this one here, which is in Bristol, which is responsible for the whole of the southwest of England with a population of about 5 million. And in 2014, we became the major trauma centre for the southwest of England. And that gave us an opportunity working up to this to change the systems that we were using to deliver care. And so we produced a management algorithm which basically involved strategic planning. We sat down months and years in advance to work out how we could best do this. It required leadership in that the major stakeholders had to drive this, lead from the front if this was going to work. It had to involve quite sophisticated organization and most importantly, collaboration between a variety of surgical disciplines, paramedical disciplines, management teams, etc. And that's why I think it may have relevance to the global perspective, in that all these features, I think, are relevant irrespective of geography. The system we have also allowed us to keep a very close eye on our patients. And I heard previous comments that in some areas of the world, it's very, very hard to do that. But we can almost guarantee 95% plus follow-up on these patients. So the plan, again, which doesn't deviate from anywhere else in the world, is we want to, for our open fractures, we want to sterilize them, stabilize them, reconstruct them, and therefore prevent long-term differences. One of the other advantages of working in a relatively small country is we can influence people relatively easily, because the population of our surgical population is small. Our population of surgeons is relatively small, is what I mean. And the BOA has produced a variety of documents which specify the standards of care that are required in our system. And this is for open fractures. And this talk is predominantly about open tibial fractures in pediatric patients. And the standards involve, these are the three, I'll just make it easy if you just see, but just to highlight them: orthoplastic care, combined delivery of orthopedic and surgical and plastic surgical care for all open fractures. The debridement, the first procedure, should be within 12 hours of injury for solitary high energy fractures. If it's farmyard or marine contamination, it's immediate. And if it's low energy, within 24 hours. The definitive closure should be achieved within 72 hours of injury. And the definitive stabilization should not occur until soft tissue coverage has been achieved. So that's our basically the parameters under which we work, and they're recognized throughout the system. And we were able to use this to introduce an algorithm for the open tibial fractures that we knew we were going to receive as we became a trauma center in 2014. And so just to take you through this, this is a relatively representative case: 14-year-old male, pedestrian versus car with an open tibial fracture. So he gets to the emergency department and he gets triaged and resuscitated. They will be pre-alerted because he will have triggered a major trauma protocol. Even though it's a one bone fracture, it's an open fracture, and that means it triggers a major trauma protocol. Our registrars, both plastics and orthopedic surgery, are required to be part of the initial assessment. And so we know we've got eyes on the ground that are immediately available. And so the initial inspection in the operating theatre has to be a plastic surgical consultant and an orthopedic surgical consultant. And this is part of the agreement that we made in leading up to this system, and we got buy-in from both departments. Because when it's assessed, the assessment in theatre is, in my view, and it's widely accepted, is the most important part of this. It's what you do first off defines how these cases are going to go. And we don't want messengers, we want decision makers in theatre. So all this business about someone talking to someone in authority through a mobile phone while they're looking at a wound has to go. It's the decision maker who's present at the time. The soft tissue and bone assessment is systematic, with the orthopedic surgeon taking care of bone assessment and resection, plastic surgeon taking care of wound excision. And our plastic surgeons are very careful about defining what they think will survive and won't survive. And so the wound is extended. And we've looked at the data very carefully, and the orthopedics consultant present 100% of the time, plastics consultant present 94%. And in two cases, there was a peri-consultant fellow who was present, so a decision maker at all times. We think this is probably the most important part of this algorithm. And so after 5 hours, this patient's had a thorough debridement of both soft tissue and bone, has a temporary stabilizer, has a vac drain. After that, they go to the high dependency unit, and whatever imaging is required, usually it's CT angiogram if they require soft tissue reconstruction, free flap, etc. And then the definitive management is in the operating theatre with a plastic surgical consultant and orthopedic consultant. And part of the strategic planning was each gives up one of their elective lists. So we've got equal buy-in to this. So if we've got a day operating, half of that will come from orthopedics, half from plastics. So we're contributing equally, and then to HDU. And in this patient, 48 hours later, he's slightly the wrong patient for a pediatric talk because he's skeletally mature, but he was 14, so he came to us, so he gets an adult treatment. But it does illustrate that this is an effective treatment. And after 18 months, he's got scars to prove it, but he's actually back to full function. Anyone who's interested, this is the first 5 years of this work has been written up in the Bone and Joint Journal. But the guts of it are the median time to union for this group of fractures was 12 weeks. No non-unions, no osteomyelitis, and very minimal coronal and sagittal plane deformity. We use hexapod fixators, probably overusing them, but we'll accept no deformity. So we use a hexapod for the external fixator cases, and we will reprogram them to make sure that there is no deformity. For the nails and plates, there's no deformity because that's part of the primary surgery. And so the conclusion, everyone knows, but I think we've emphasized it in our practice. If you go in early, go in hard, and aim for anatomical alignment, you can expect very good results in this group. And this is just to illustrate the extreme of management. This is a 12-year-old boy who had his leg caught in the wheel arch of a bus. He had a reasonably straightforward tibial fracture, but he had a complete circumferential degloving from his knee to his foot. And so that's sensate plantar skin. And so in discussion, amputation was certainly considered, but it was thought worth a salvage chance because he had a reconstructible bone, he had sensate plantar skin, so it became just a very extreme soft tissue coverage problem. And I illustrate this slide because in terms of cooperation, when I build these fixators, I build them with the plastic surgeon in mind. And so initially we build a half external circular fixator to give them access to their free tissue transfer. The thing that's going to make this work is the soft tissue coverage. And so if they can't get a good anastomosis, this will fail. So my job is to make sure that the tibia is stabilized whilst they can do the soft tissue coverage. And that's where my colleagues almost can't working around this frame. And that was the initial result. It was a propeller flap from, a parascapular flap with skin grafting. And 18 months, he looks like that. And that's him in a clinic appointment. And walk back. And so in our service, it enables global service change. We have a captive population, and that supports regional innovation. And it also allows us detailed surveillance so we can feed back into the parts of the system that require improvement. And that, again, we've used to prevent long-term differences in this relatively small cohort of open tibial fractures. So the global relevance to this forum, I think, is that change is driven by strategic planning, by leadership, by organization, by collaboration. And thank you very much for your time.